Good morning, everyone, and welcome to this live-streamed author interview. I'm Mike Charles, and I'm an editor of Anaesthesia, and I'm delighted to be joined by Dr. Chris Varghese and Dr. Laurent Gavaret as well. Delighted to have you both with us here this morning. I'd like to know a little bit about you. Chris, can you tell us what your background is?
Hi everyone, and hi Mike. Thanks for having us. My name's Chris Varghese. I'm a junior doctor here at Auckland, New Zealand. Currently a PhD candidate with the University of Auckland and member of the Tasman Collaborative. Look forward to talking more about our paper.
Great to have you with us, Chris, and Laurent as well.
Yeah, hi, thanks, Mike. Thanks for having me. I'm also a junior doctor. I'm working in New South Wales in Australia. And I was part of the Tasman Collaborative and still am with Chris and a bunch of other people who worked on this project.
Great. Well, thanks for giving up your time this morning. The paper's obviously going to be going online today, and I'm sure our readers are going to want to know all about it. And this is a sort of deep dive into the background behind the paper and why it's important for clinicians, really. So I hope everyone who's watching at home enjoys the next half an hour or so. And a bit of background about the paper is it's got an acronym, which is OPERAS, which stands for the Opioid Prescriptions and Uses After Surgery. It aims to quantify the current global practice of opioid prescribing and consumption patterns in patients after discharge from common surgical procedures. And as well as that, identify factors associated with increased opioid consumption. So this paper has real global relevance, and it's not just anaesthetists who should be picking up this paper and reading it. It's anyone in the healthcare system who looks after patients who have been prescribed opioids or are on pathways where opioids are prescribed, and that's secondary and both primary care as well. So this has got some really wide relevance for all sorts of healthcare professionals out there. And I noticed that the paper, and you can see there that on our backgrounds, there's not named authors there, and the named authors, of which there are plenty, are in the supplement. But this was actually authored by the Tasman Collaborative. I wondered if you could tell us a little bit about that and how it came about and what else the group has done as well.
Yep, so you're right that we've authored it as part of the Tasman Collaborative, which is our group, which is an Australian and New Zealand medical student and trainee-led collaborative research network, which was really inspired by surgical collaborative networks in the UK, actually, like StarSurge and Eurosurge. So we set up the group to work on projects and also work on other people's projects to provide data from an Australian and New Zealand context. We also are interested in promoting research amongst medical students and trainees. So part of why we picked this project is, like you touched on, we think it's an important topic for everybody, and especially junior doctors and medical students, who are often the ones, at least in our context, who prescribe opioids. So part of why we chose this topic was to get as many people involved in research as possible, and collaborative research as a way of getting large numbers of patients and hopefully providing meaningful data. So in addition to research, we also run educational events for students in particular. We run workshops and journal clubs and other sort of events that help to introduce research.
I mean, I had a look at the website, and it's incredible, and there was nothing like this when I was a medical student, obviously, and it's incredible as well that you got links in with the StarSurge and Eurosurge groups, and obviously we've had lots of their papers in the journal, and we had the big COVID surge paper as well, and all sorts of other things, and I think there's going to be other papers from that group in the pipeline as well. So that's really amazing. And you actually managed to include a lot of patients from 144 hospitals in 25 countries, and I mean, those numbers are simply staggering. I mean, anyone that's tried to do research in their own hospital will know how difficult that is. And to do that in 25 countries in all those hospitals, it blows the mind, really. How did you do that?
I think, as both of you guys have already touched on, that collaborative model is really catching on as a modality for running research studies of late. I mean, it's really matured through global experiences through the COVID surge studies, which have been highly impactful. I think the vehicle in collaborative research that is able to deliver such high breadth and depth is the mini-team model, and which empowers the local collaborators from their own hospitals to really drive the study locally. We're really fortunate to have stellar regional leads and national leads who really took on the study and shared the responsibility of its delivery. engaging as many sites in their respective countries and geographic regions as possible to ensure we get a really wide reach and can generate generalizable findings from our research.
Right, so yeah, global problem and a global collaborative to potentially provide some solutions to that. That's absolutely incredible. Just a slight technical question about the methods. How do you determine morphine milligram equivalents? Is there an easy way to do that?
So we actually used primarily a calculator that we use in Australia and New Zealand that's published by our College of Anaesthetists, their Faculty of Pain Medicine. They also have an application. It's called their opioid conversion calculator. So that's what we use in clinical practice here. So we use the same thing, but integrated it into our data collection. So for data collectors, all they had to do was input exactly what patients were prescribed. For example, say endone 5 milligram tablets. And the reason we did that was to reduce error in data collection, but then we used that calculator to convert it on the back end. We came across only a couple opioids that weren't in that calculator, and for those opioids, we used a literature search and a consensus sort of model from our scientific advisory group, which included consultant anaesthetists, pain specialists, and a professor of clinical pharmacology. We've put those ratios in our supplementary materials as well for anyone who's interested. But the majority of the opioids are the ones we probably see most commonly in practice, and they were all in that calculator. Yeah.
I think that was really useful actually, because for me, I can pick the paper up and instead of getting lots of complex numbers around lots of different medications, you've just got the headline figure, which is morphine milligram equivalents, which is really clinically useful. But there were some more complex methods, I think, in terms of the statistics. Can you just briefly, for those people who might be intimidated by things like beta coefficients and bootstrapping and QQ plots, can you just sort of briefly explain a little bit about how they were done and what they are and why they were important?
Yeah, absolutely. So one of the key points of difference of the OPERA study is we've tried to retain that continuous data that we've collected from the patients in such a painstaking manner, retaining that morphine milligram equivalence unit. So we've used a lot of linear regression models to assess some of our hypotheses and answer some of our questions. So that's where some of those technical terms come in, and I'll go through those in a little bit more detail. For example, QQ plots is something we looked at to interrogate the underlying data distributions, and that's important to make sure we're meeting the assumptions for these specific types of models that we report in the paper. Secondly, we use beta coefficients as a statistical estimate of effect size, and that's the output from our linear regression models. And these can be understood as the magnitude of change in our dependent variable, which most commonly in this paper is the quantity of opioids that patients consume in the week after surgical discharge, and how that magnitude change varies by a unit change in each of the independent variables. So we look at a lot of demographic factors and also the quantity of opioids that we prescribe at the time of surgical discharge as those independent predictors of what patients are likely to consume. And finally, bootstrapping is a methodology where we leverage the observational data that we've collected and recursively resample from the distribution. And what this allows us to do is provide some confidence intervals around some key measures of effect. One of the key findings from that exercise was that we prescribe about twofold what patients end up consuming in that first week after surgery. And we were able to show that with a tight confidence intervals around that 2.22 number we report.
That's fascinating, isn't it, for people who are reading this paper, that there are so many other useful things you can get from interrogating the methods of a full paper like this in terms of the statistical learning, as you mentioned in the supplementary material about how to convert between different opiates and all sorts of other things as well. And I think we actually had one of our statistics editors look at the paper when it went through the peer review process, who was very complimentary about the methods used and in order to generate the conclusions. And often we do find in these sort of large observational studies that there's a temptation for data to be overanalyzed and to use these complex methods to try and tell you something and try and goad the data and bring something out of it. But I think for this, the peer review was very positive about the methods used and the integrity of the statistical analyses. So well done to the author group for that. Back to sort of clinical things now. What was the primary outcome and why did you pick it and why was that felt to be important?
Yeah, that's a great question. And our primary outcome was the discrepancy between what we prescribed and what patients consumed in terms of opioid quantities. And why we chose that, I think, requires a little bit of historical context. So the OPERA study was motivated originally by local findings by Luke Peters and Peter Pockney at Newcastle, Australia, who found in some of their local data that there was a striking discrepancy between what we prescribe and what patients consume after simple general surgical operations such as appendicectomy and cholecystectomy. So that got us to think, and we were quite alarmed that this discrepancy that we're used to seeing predominantly from North American data actually possibly applies more globally than we initially assumed. And so that's kind of where the OPERA study was born, as a really suitable target for Australian and New Zealand collaborators and a worldwide collaborative study, hence the attempt to gather sites from all over the world. In terms of the specifics of the primary outcome and that discrepancy variable, we looked at a 1 week time difference. So looking at the quantity of opioids consumed in the first week after discharge for two main reasons. Firstly, to be pragmatic and optimize on patients' recall bias. So we get a really robust measure when we do ask those questions. And secondly, to align with many of the guidelines from our literature review, which identified that 1 week is a relatively common and optimal duration for which we should be prescribing opiates after many surgical procedures.
Yep, I think again it comes back to methods. Something we were really proud of in our study was using patient-reported outcomes, and it was really important to us to include what patients thought. And again, that's where that 1 week timeline and that idea of looking at what are patients consuming as the primary outcome, but there's also plenty of secondary outcomes looking at how patients report their quality of life post-discharge, how they report their pain, how they report their side effects and those adverse effects of opioids. It's really interesting data, and it also is an interesting application of the collaborative model that we hadn't really seen before. Usually it had been predominantly based on medical records and auditing. So it was a bit ambitious, and initially we didn't necessarily plan to go global. We just had a lot of interest and then expanded our plan.
Let's move our attention to the main messages from the paper. If you're able to pick maybe one or two, what would they be for you?
I think the one that Chris has said, if everyone just remembers one thing from this paper, it's that we're prescribing double what people consume within that first week after discharge, which is a lot of opioid ending up in our community. And we know, and I'll talk about this more if you'd like, but we know that people don't dispose of their opioids safely, and most of it will end up in their homes and in their community.
Yeah.
And the second thing that we would like to also sort of highlight is that the more opioids we prescribe, the more people consume, at least looking at the data from an observational point of view. And that's something that's been shown in other papers on regional levels, but not necessarily on a global level like we've done. And I think that has implications for us as prescribers when we think about what will be the impact on the patient with this script that I'm giving them. And then if I can add a third one, looking at the global data is the disparity. Like Chris said, we were really lucky and to have data from both high income countries and low and middle income countries. And part of that came out of our goal to look at Australia and New Zealand as an area of the world that hadn't necessarily been studied as much as the US. And we found that perhaps not unexpectedly, people in higher income countries are prescribed more opioids on discharge than low to middle income countries for the same surgeries. And it's something to consider when we think about equity of access to pain relief after surgery. And also when we think about the opioid crisis and the implications that could have across the world in other parts of the world, especially low and middle income countries where it's perhaps not as recognized.
There are so many take-homes from the paper. One thing that struck me was that, like you say, I mean, that's a shocking statistic, isn't it? That only half of those opioids that are prescribed at discharge are actually consumed, and the other half, who knows where they are, we'll touch on that later. But there was also, on top of that, an association between the amount prescribed and the amount consumed as well. Why might you think that might be?
Yeah, when we were looking into this in other studies, it's hard to tell. You don't know if people are consuming more, they've been prescribed more for good reason. And maybe that's outside of what you can capture. But there is a train of thought that comes out of the psychology literature that people are influenced by what you prescribe them, and you set an expectation of what they should need. So if you look at the obesity literature, there's findings that portion sizes influence how much people eat, independent of hunger. And similarly, when you look at studies, there are studies that have been done, for example, on women after cesarean sections, and in that cohort that you don't expect to have necessarily preoperative opioid use, you find that women who are prescribed more opioids consume more opioids. So whether it's sort of it has an impact on the patient that they believe that they should take more because they've been prescribed more, and that's what the doctor wants from them. Who knows? It's an interesting area, but it's definitely been demonstrated in other populations, other surgeries, and also outside of opioid prescribing as its own topic.
I mean, that's a fascinating finding, isn't it?
Mm.
And those opioids that aren't taken, are they being disposed of, or are they ending up in cupboards or perhaps even elsewhere?
Yeah, in the literature from the US, they find that probably about 3/4 of patients don't dispose of their opioids; they hold on to them. In our settings, it's hard to tell, but it's probably the same. Part of that is because, at least where I work, there's no incentive for patients to dispose of their opioids, and I think that maybe as humans we have a tendency to want to hold on to medications just in case.
We have a
Who
whole
knows?
cupboard of
that's
medications that are probably out of date or something like that from.
yeah,
I'm sure most
and
people
people do that with antibiotics. Yeah, antibiotics. You hear people saying that they've got an amoxicillin in their cupboard, and when you hear that, you think, how have you got that, or why would you take that without being told to do it? But we know people do.
Yeah.
And then where does it go from there? In the US, of people who misuse opioids, more than half get their opioids from a friend or a family member, and it's probably the case elsewhere. In our study, we found that only 30% of patients received documented advice on how to dispose of their opioids, and that's definitely an area that we can all work to improve on, to try and address that gap, as well as the quantity we prescribed in the first place and trying to be more accurate in matching prescription to anticipated consumption, understanding that that's a difficult thing to do.
Yeah. Chris, is there anything you want to add into that?
Yeah, I just wanted to point out that that discrepancy obviously highlights that the amount we prescribe is a modifiable factor, and actually oftentimes it's independent of analgesic requirements, and that some of the hints that we're getting from this paper acknowledging the limitations of an observational study design, but definitely something like Laurent's saying for further research and optimization of practice.
So moving on then, in that case, about what should be done, there'll be a lot of anaesthetists reading this paper and watching as well, because obviously we're a perioperative journal, although we do have other readers as well. We all have surgeons and plenty of other people, members of the public as well, but the majority of people are probably going to be anaesthetists, and they don't, certainly in the UK, prescribe discharge medication for patients. It's usually the sort of the team who's usually looking after the patient in the hospital, which are tend to be the surgeons in the UK. Is there anything anaesthetists can do in the perioperative period to reduce the risk of opioid-related harm in the community, as you've seen in this paper?
Yeah, absolutely. I think first and foremost, we're all prescribers of opioids, and therefore we all share part of the responsibility of how these opioids are used, irrespective of the setting. But another really interesting finding from our modeling and one of the core results of the paper is that one of the most influential predictors of the amount of opioids patients consume at home after discharge is the quantity of opioids that they consumed in the day prior to discharge. So anesthetists in prescribing a portion of the inpatient opioid burden, it's particularly relevant for day case surgeries or surgeries with short lengths of stays after the actual operation themselves, have a large impact on the requirements and analgesic requirements in the post-discharge setting. So that's not to say that there's a lot of modifiability in terms of that metric, but and we also know that adequate management of pain as an inpatient is a crucial aspect of ensuring adequate pain management as a whole. And it's something that we're able to do with a lot of safety netting in a hospital environment. But I think in terms of shared responsibilities, anaesthetists, junior doctors, surgical teams as a whole, we can all contribute to ensuring that patients have adequate education around side effects, appropriate disposal of opioids, and a good understanding of the analgesic ladder and escalating from simple analgesics. And that's something we found that was done quite well overall globally, is the co-prescription of non-narcotic analgesia to ensure that there's a multimodal pain regime in place.
Yeah, I think thinking about clinicians in general, so coming from the perspective as a junior doctor, the first thing is really recognizing the issue of opioid use and our responsibility as prescribers. And then secondly, I think hopefully this paper will be reassuring to clinicians that we are tending to overestimate what people need rather than leaving them without enough medication. And that's something, some of the feedback we got from peer review and from other working with other people and talking about this topic is people really being worried about patients going home without enough pain relief. And I think we can be reassured that that doesn't seem to be the case across the board, across different specialties, different procedures and different surgeries. If anything, we're overestimating and overprescribing by 2 times. I think in terms of what else we can do practically, we're really hopeful that some of the data from this paper will help provide procedure-specific estimates of typical opioid requirements post-discharge, understanding that opioid prescribing should be personalized, and some people will have greater requirements for different reasons, like alcohol use or smoking or other things. But we can hopefully give some estimates to, again, reassure people that they're providing, who are unsure, might not have less experience, like junior doctors just starting a surgical term. And then I think as well, what we talk about in our discussion is that the duration of an opioid prescription, so the amount of time in weeks that you're prescribing opioids, is really what's associated with persistent opioid use in the community. I think there was a stat that we found that for every refill and week of opioid prescription, you have a 20% increase in opioid misuse. So that was, again, in our study, we only looked at that first week after discharge, but I think that's a really crucial point. And sort of thinking about the bigger picture and the patient's whole journey, at the end of that first week, how do we hand over care to the GP and family medicine for ongoing opioid prescribing if it's needed, knowing that for most people it won't be. And so we don't need to prescribe longer than a week for most of these surgeries that we've included, which are listed in our study, but include things like lap appendectomies, laparoscopic cholecystectomies, those sorts of things.
That 7-day period seems to be key, doesn't it?
Yeah.
I think that's a really good number for people to have in their mind, that potentially if opioid use persists after that period, then that should start to ring alarm bells. But what other things can clinicians do to reduce the risk of persistent opioid use in the community following surgery? And that's not just anaesthetists or secondary physicians or primary care healthcare professionals. What can we all do to reduce that risk of persistent opioid use?
I think pain is really complicated, and anaesthetists reading this will probably laugh when I say that, because they know that better than we all do. But thinking about simple things like non-pharmacological management of pain, the understanding that pain, like you said, is a warning. And if you're having persistent pain at 7 days, should that be prompting you to be reassessed rather than to keep treating yourself at home with opioids? I think bringing the community along and bringing the patient along as well in a shared decision is important. And so education about the opioid crisis, persistent opioid use, and explaining that to patients as well. When you're discussing your prescribing choices and quantities and things like disposal of opioids, like explaining to people, this is not a medication you should have lying around the house for your kids or for your friends. This is something that if you don't need it anymore, just drop it off to the chemist and they can dispose of it for you safely. Things like that, and why that's important. That's something that actually, since working on this study, I've started introducing into my own practice and in talking to people when I send them home with a script.
Yeah, I think communication in pain medicine is so important, isn't it? And setting expectations and making reassessments as well, like you've mentioned. Chris, is there anything you want to add to that? Any final thoughts?
Yeah, I think Laurent hit the key points there. For me personally, working on the study has already changed my practice as well. And the first thing it points me to do is take pause when I'm thinking about prescribing an opioid after someone's going home after surgery. I've seen the numbers from this paper, and it's really helped me estimate when an opioid is appropriate and how much is appropriate and for how long. And that data is just so invaluable already as a junior doctor. So I encourage everyone to kind of dig deep into the tables and figures presented here and see if there's something useful in there for your practice.
Yeah, I completely agree with that, Chris. Just to reiterate, the paper is now online. You can scan the QR code in the top right-hand corner of all our backgrounds if you wish. We'll also be putting the links up on Twitter and everywhere else. It's free to access. It's on our journal homepage. It's very easy to find. Please do read the full paper. There's never any substitution for doing that. Have a look into the methods. There's plenty to learn. And I think, like all three of us have said today, this is practice changing research, and this doesn't come around that often, actually. And I would encourage everyone to try and think about their own practice as a result of the findings of this paper. Send us your letters. Let us know over on Twitter if you've got anything else to add. Both Chris and Laurent are on Twitter, and you can tag in the journal as well, and we will be delighted to respond. But that's been a great half an hour. I've really enjoyed it. I hope you guys have too. And I look forward to seeing the response to the paper, and I look forward to seeing the attention it gets thereafter as well. So goodbye, Chris and Laurent, and thank you very much.
Thanks, Mike.
Thanks, Mike.